Welcome to the Center Collaborative, Creative Solutions in Behavioral Health and Criminal Justice, brought to you by the Oregon Center on Behavioral Health and Justice Integration, which is also known as the Center. We at the Center are all about solutions. Our job in Oregon is to facilitate improvement of the system so behavioral health and criminal justice can work better together to engage people in treatment while promoting public safety. I am your host, Chris Thomas. I hold a master's degree in clinical psychology and have focused on the intersection between behavioral health and criminal justice for 20 years. Over 7 of those years were behind the walls of a maximum security prison. During this podcast, you will have the opportunity to sit in on real, in-depth conversations with experts about complex topics in a way that is both fascinating and digestible. We will focus not just on what is wrong with the system, but what is going right and how we can work together to evolve. This podcast is a conversation in a series of conversations where we touch on people's legal rights and their options related to seeking medical care. Since our conversations are intended for informational and educational purposes only, they are not a substitute for or a reason to delay seeking professional legal or medical advice. Joining us on today's episode is Sue Goldberg, Senior Director Decision Support for Umpqua Health Alliance CCO, and Cheryl McDonald, LCSW Crisis Program Director for ADAPT Integrated Healthcare, to discuss Douglas County's use of the Impacts Grant through the Criminal Justice Commission. The flexible spending from the grant has allowed Douglas County to reach a specialized population in a completely different way, saving lives and impacting the bottom line. Douglas County has used the grant money to hire 3 navigators, a part-time therapist, fund a sobering center, 2 crisis beds, upcoming temporary housing, and also access to peer services. I learned so much in my conversation with Sue and Cheryl. I think you will too. Welcome to our conversation. Cheryl and Sue, welcome to the program. We are thrilled to have you with us today.
Thank you.
Thank you for having us.
Well, to start off, I think the listening audience would be interested in hearing more about the grant that you were awarded, what it initially was intended for, and then we can talk about the unique program that is happening in Douglas County to meet the needs of the specialized population. So with that, Cheryl and Sue, would you like to talk about the Impacts Grant from the Criminal Justice Commission?
Sure. The Impacts Grant, IMPACT stands for Improving People's Access to Community-Based Treatment, Supports, and Services. It was funded under Senate Bill 973, which provisioned $10 million of legislative funding to qualified organizations. Douglas County applied and received $1.4 million through the ADAPT Integrated Care program. And the purpose of the grant was to address shortage of comprehensive community supports and services for individuals with mental health or substance use disorders, leading to their involvement in the criminal justice system. Currently, we have about 333 individuals in the program.
My understanding of the grant is that it was designed to reach people who traditionally don't meet the criteria for jail diversion because the diagnoses aren't generally an SPMI. It allows for both mental health and substance use diagnoses, and it's for folks who come to the attention of emergency services either through the jail or through the ER. Is that correct?
I think that's a really good understanding. Their criteria for admission into the cohort is that individuals need to have 4 or more incarcerations in 1 calendar year and be frequent emergency department utilizers. We certainly see some overlap with clients who have those SPMI diagnoses that would qualify them for programs like jail diversion. But I think this program is really unique in that we don't require the SPMI diagnoses. People can have substance use disorders or social problems that contribute to incarcerations, and they still qualify for admission into the cohort.
So, this is really allowing funding to work with folks in a different way that has happened within both the traditional criminal justice and behavioral health systems in order to uniquely meet people's needs that haven't been able to be met before with prior programming and prior funding. I'm curious, Cheryl and Sue, what Douglas County has done with the Impacts Grant. I know that in meeting with you before, I was really excited to hear about the unique way that you are using the money. So, I'm wondering if you could tell us a little bit about Douglas County's program.
So, our initial grant allowed us to hire two full time employees to serve as outreach navigators. And these are the staff that are going out to the community. They're going to the jail, they're going to the hospital, they're going to encampments, anywhere that our cohort members are located. They're going out to try and make contact. It also allowed us to do some work, and Sue, you can use the terms that I am missing, but that work with collective medical to really get that established. And then we also were able to use some funds for two crisis resolution rooms, which will be opening shortly, and our sobering center, which has now been open for about a year.
So let's talk about how that looks a little bit different than what you would have been able to do before without the money. With your new staff and the way that they are interacting with folks in the cohort, how does that look different now than what that would have looked like before without the Impacts Grant money?
One of the biggest draws to this program is that we don't place any kind of requirements on engagement with treatment, which I think is really different than other CMHP and SUD financial resources. In order to take advantage of those financial resources, you needed to be engaged and an active patient of that organization. The Impacts program is different because we don't require people to engage in mental health or substance use treatment in order to receive support from the program. The program really is meeting people where they're at. Oftentimes, that looks like us going into the jail, meeting with a cohort member, and really allowing that cohort member to be the expert in their lived experience. They are the experts in what will work for them and what will not work for them. So we really try to empower people. You tell us, what is it that you need to be stable? And for different people, there's a variety of different needs. For some people, they really do identify that they need to get in substance use treatment or they need to get back in with their mental health provider. For other people, they identify they need to get back to work, a job or employment, being able to make income and support family or housing is what's standing in their way.
And how does attending to needs that are not met through traditional systems helping folks stabilize and eventually get into treatment?
I think if we look through the lens of social determinants of health, one of the biggest barriers that our cohort members face is the lack of adequate housing. By removing that requirement to engage in services, if we're talking about someone who's living outdoors, it's incredibly difficult to engage in traditional healthcare. It's difficult to be able to find transportation to make it to an appointment at 8 o'clock sharp. It's a difficult system to navigate without adequate housing. If we remove that requirement for people, if we go to people where they're at, if we say, hey, look, you get to tell me what it is that you need to be stable, and then I get to help you with that. People are much more willing to engage, and we see people identify this is my need. We had someone recently who was coming out of a period of incarceration who said, I just need to get back to work. That's what I need. I have a job lined up, but I need steel-toed boots. Okay, so we were able to use impacts funds to get this person a pair of steel-toed boots. They were able to go back to their previous employment, and they've had no further incarcerations since that occurred.
And it's amazing the price of boots to support someone continuing to do well versus if we weren't using that funding for something like steel toe boots, not only the cost to that person, but also the financial cost to the system. It's outside the box thinking way of addressing the issue that we usually won't do in the traditional system.
I think that's a really good way to explain it. So, for the cost of a $40 pair of boots, we were able to support this person getting back into employment where they could then sustain their lifestyle, sustain housing and adequate food and the resources that they needed to be stable.
So tell me also about your crisis beds that are coming online. What is that going to look like?
Yeah, we're expecting 2 crisis resolution rooms to be open. We're hoping by the end of February they will be ready to go. They're on the same campus as our mobile crisis center and our sobering center, which is right next door to our detox facility. So all of those systems are able to work together in navigating through the different programs, which is really helpful for clients. Our crisis resolution rooms will be 23-hour resolution rooms. There'll be independent rooms with a bed, a refrigerator, a shower, all of the things that people might need just to take a brief respite from the immediate crisis. I think that oftentimes crisis can be complicated by lack of sleep, lack of nutrition, lack of hydration. If you haven't eaten or slept or even drank water, your perception of a crisis can get infinitely worse. If we can offer folks a safe, quiet space just to take a brief time out and then readdress things the next day, that's our hope with the crisis resolution rooms.
That's so exciting. Listening audience, and think about if you haven't eaten all day, or oh gosh, if you haven't had your coffee in the morning and you have to go through meeting after meeting, and let's say that you get the email that something has blown up and there's a fire that you need to put out, directly speaking, at work, and how well you do when you haven't had your coffee or you haven't been drinking water or you haven't eaten, and then multiply that by 1,000 when you're thinking about a crisis situation for someone who is experiencing behavioral health symptoms.
Exactly. I think a lot of people, myself included, know what it's like to get hangry. It's hard to think, it's hard to process, it's hard to be nice, it's hard to talk rationally. So, if we apply that to someone who's living outdoors, they haven't eaten in 12 hours, they haven't had a safe, warm spot to rest and recuperate, and then we add a crisis on top of it, it's really difficult to manage that crisis event. We're hoping with the resolution rooms, we'll be able to help at least a few folks at a time experience a brief respite from their crisis.
And we also know that with crisis, as I recall, that most of the time, if you are able to give someone a respite, that period of time tends to be fairly short. And then you're able to get someone back on track. So it allows folks to get stabilized within a shorter period of time without having to go to higher levels of care and continuing to escalate a crisis. Am I recalling that correctly?
That's been my experience. Most crises are time sensitive. It takes a lot of body energy to sustain a high level of crisis. So, if we can support someone during that immediate crisis perception, let someone rest, relax, get some food, get some sleep, and then oftentimes we can reapproach within just a few hours and do some active problem solving around the cause of crisis.
So tell me about your sobering center, because I have talked to lots of counties who want sobering centers, but they're really difficult to set up and they're really difficult to fund in the long term. So I'm wondering if you can talk about some of the barriers to the sobering center setup and then what you all are looking forward to for yours.
Sobering Center was part of the initial grant application, and funding supported that. And Douglas County did not have a sobering center, and so ADAPT used the funding under the impacts grant in part to build out the sobering center here in Douglas County. I think it's been highly successful. We went and toured it. It's well built. I think it provides the community and law enforcement a good opportunity to just bring people into the sobering center versus bringing them to the jail or the ED. So we're reducing overall healthcare costs and justice system costs by diverting them through the sobering center.
So the sobering center is a specialized place to bring someone who is currently under the influence of substances, but the jail isn't a great place for that to happen. Sobering up in a jail, that's not what jails are intended to do. And the ED, that's not really what they're intended to do either. They're both really expensive places for someone to sober up. So the sobering center is an opportunity to have that in a place where folks are being observed to make sure that everything is going okay, but at a much less cost than either the jail or the emergency room, is my understanding of sobering centers.
It does allow people to become sober in an environment with reduced cost, but it also allows people to become sober in an environment where they're supported by treatment-focused staff. We have a peer support that works there who is more than happy to help people engage in a variety of treatment-oriented services or other community resources that they may identify as needing more than substance use treatment. If somebody does want substance use treatment, one of the benefits of our location of the Sobering Center, which is right next door to our detox, is we have excellent communication with the detox center. And we've had a lot of success with getting people straight from the Sobering Center. As soon as they're sober enough to be safe, we get them into detox. We've had a couple of instances where we've been able to get cohort members from the Sobering Center over to detox and then into our residential substance use treatment facility.
So not only is it less expensive, it's also a gateway into treatment.
Exactly.
And generally in the ED or the jail, that is not the case, is my understanding.
Yeah, it's not a treatment-focused environment at the jail or at the emergency department. And I think that's part of the reason that we've had such good buy-in for the Sobering Center. We have fantastic law enforcement in our area, and we have excellent relationships with the law enforcement and with the jail. The jail has been an active participant in the steering committee developing this program, and they fully recognize that jail is not a therapeutic environment. So if we can connect someone with something more of a therapeutic environment and increase their chance of engaging in treatment options, then we can really reduce the likelihood that they'll be back in the jail or back in those circumstances.
It's doing something about what is bringing that person to the attention of law enforcement and addressing those needs versus just jail and then release. Jail is designed for something completely different than a therapeutic environment. There's nothing wrong with jails, and that's not a knock on a jail. It's just there's a difference between a therapeutic environment and a jail. And if someone is coming to the attention of law enforcement because of their behaviors that would do better in a therapeutic environment to be addressed, that's no knocks on the jail at all. It's just about getting people to where they need to be in order to decrease the probability of seeing them again, it sounds like. Heads are nodding, y'all. Just so you know, heads are nodding.
Reducing the recidivism rate, right? Yeah.
Yes.
That's the
Yes.
goal.
And that's what we want to do, right? We want to reduce the recidivism. We don't want people to come back.
Many of these individuals cycle through the jail quite frequently. In fact, the police in our area are on a first name basis with these individuals. And sometimes it requires one or two police officers to respond to a call for a particular individual. They know ahead of time who the individual is, what they're potentially going to encounter. And so now you have two patrol cars showing up for an individual that ends up going to jail, then cited perhaps and released or not. But it just seems like a much better solution to try to route them through the sobering center and then potentially into the detox and then the residential treatment. And I think the way that it's set up here in Douglas County, as Cheryl was saying, where the sobering center is accessed behind a locked gate that the jail and the police officers have access to. They bring them in and then they go into the sobering center. And as Cheryl mentioned, if they are acceptable to considering detox, it's just a walk through one building to another, into the detox and then to the residential program. Great concept, nice campus. And we're real excited about the funding that we got from the Impacts grant to enable these infrastructure costs to be covered.
Speaking of the funding, because I think our listening audience could clearly see how helpful it is to have navigators that work with folks in a different way and respond with folks in a different way, and crisis beds and sobering centers. I think it's also really important, though, to talk about how impactful the Impacts grant was to be able to have these resources in the community and how difficult they are to fund through the traditional system. And that doesn't get talked about very much. So I'm wondering if you could talk about that a little bit and the struggle to fund these specialized services through the traditional system if you hadn't had this funding through the Criminal Justice Commission.
On behalf of the Coordinated Care Organization, Umpqua Health Alliance, the healthcare costs for the Oregon Health Plan population in our area come through the CCO. A lot of the services that Cheryl's team is doing out in the field may not be covered because they're out in the community meeting the people where they are. And it's not a billable or allowed service.
I think that gets missed sometimes. Folks don't realize that Medicaid tends to be fairly strict on what you can bill for and what you can't bill for. And the Medicaid system is built around the traditional way of receiving medical services. So you have to show up on time, on the correct day. And that is really difficult for engagement in certain specialized populations, particularly the population that we're talking about, who's the focus of this grant. And the traditional funding doesn't really follow what is needed to reach this population. And that was what was able to happen with this impacts grant. And so I think that sometimes that gets lost and people go, oh my gosh, why isn't mental health doing this? Because you have to pay for it. You have to pay for those clinicians. You have to pay to get out there and do the service. And if your funding only follows a traditional path, it makes it really difficult to do that. And that was why this impacts grant was so helpful in being able to fund these services in a different way, to be able to reach this population and engage with them.
I think that's been a huge barrier to serving this population, the incarcerated population, those of whom are on Medicaid. Their Medicaid is then turned off as soon as they're incarcerated, and it doesn't get turned back on until they are exited from the jail. So in order to provide a service, we can't do billable services while someone's incarcerated. So it's been a very specific set of individuals who actually are able to go into the jail and work on engagement. Otherwise, there's traditionally been a lack of therapeutic services offered while someone's incarcerated.
And then also for the sobering center and my conversations with other counties, the barriers to being able to stand up a sobering center and then continue to fund a sobering center based upon the traditional system versus the monies through the impacts grant. And I'm wondering if you can talk about that as well, because I hear lots of counties talk about how they want one, but how difficult it is to fund one.
It was difficult to fund one, and it continues to require some creative thinking. Luckily, the Impacts grant was able to help with a significant portion of the startup costs. And through that process, we were really able to go to the county and to each individual city within the county and get a lot of great buy-in from community partners about the importance of having a sobering center and potential cost savings to each entity.
So you're able to do a little braided funding.
There you go.
Oh, yes. I loves me some braided funding. For the listening audience, everybody who's involved gives a little in order to support a program versus it all coming out of one agency's pocket.
I wanted to also say that the services provided in the sobering center are currently not covered as a billable or allowed healthcare service under OHP. So they're doing it basically from grant funding or community contributions.
So can you talk about, because I think this is really important, something that the listening audience needs to consider is that you could send someone to the emergency room or the jail or a sobering center. So we can talk about the costs with all of those. But the costs of the services that are in a sobering center versus very expensive in an ED or a jail, which aren't designed to do that. What kind of services are we talking about that are happening in a sobering center that are not covered by Medicaid?
We're talking about peer support services, making phone calls, accessing resources that the individual might need. We're talking about up to 23 hours of supporting each individual in their own individual rooms. And during that time, we have laundry facilities there. We have shower facilities there. Oftentimes, folks who are intoxicated in public may come into the sobering center without adequate clothing items. It's 30 degrees outside and someone will come in without shoes or a coat. We found that slightly more than 50% of the people coming into the sobering center are unhoused. And so when somebody is taken from their encampment or public location and sent to a sobering center or jail, they oftentimes lose all of their belongings. They lose their tents, they lose their sleeping bags, they lose those items that are necessary to sustain health and well-being while living outside. And so those items are also provided to folks. Take some food with them. We also provide naloxone to people as they're exiting. We want folks to take several doses of that with them out into the community. So a wide variety of services are being provided. We've hoped that at some point in time, those services will become billable. But for right now, we have a fantastic manager who is an expert at writing small grant requests, and those have been well funded. So it's been helpful.
And for the listening audience, naloxone is used if someone is in the middle of an overdose in order to, the easy way to explain it is to reverse the overdose, but to block the uptake of the opiates. I know you will have a better way of explaining that than I do.
That was pretty good.
Was that pretty good? Yeah. So basically, if someone's overdosing, you can spray this in their nose and significantly decrease their chance of dying. You really give them a chance, and particularly with the narcotics that are out today, you may have to give someone quite a few doses in order for them to have a chance of surviving that experience before EMS can arrive. So it's really important that this be sent out with peers, because who's going to see someone else overdosing? It's peer to peer. When someone's in the middle of overdosing, they're unlikely to come to the jail or to call the police or go to the emergency room, because that's a very uncomfortable place to be for folks. So for peers to have it for peers, we're saving lives in the community by making those available. So, I love to talk about data. It is one of my favorite things. And Sue, I know that you love to talk about data. So I'm wondering, what kind of initial findings are you all seeing with the way that Douglas County is using their impacts money, and the difference that is making both in lives and on the bottom line as far as healthcare and criminal justice costs?
We're excited about the analytics side of this grant. That's Umpqua Health Alliance's participation under the Impacts Grant in Douglas County. And we were successful in initially getting a flag for all the impacts cohorts loaded into Collective Medical, a regional database for these individuals as they cycle through the EDs in the Pacific Northwest region. That's extremely helpful to identify the individuals, because they don't always show up in our local ED department. They may show up and down the I-5 corridor. So that was one of our first big accomplishments on the analytics side, was getting that. Under the second grant funding, which we just got in July, the Criminal Justice Commission awarded us another $1.3 million. We were able to establish a daily jail data feed of bookings and releases so that we can identify these individuals sooner and being proactive rather than reactive in identifying individuals frequently the jail, and add them to the cohort for Cheryl's team to then go and do outreach and engagement with them. We're real excited about that. I believe we're the first in the state to negotiate a data sharing agreement with the law enforcement agencies, and it's been extremely successful getting that daily information and then identifying individuals sooner as they come through 4 or more times in the jail.
Cheryl, I'm wondering if you can talk about the difference it has made for you and your team to have both of those data sets for folks to be flagged as part of your cohort, not just in Douglas County, but up and down the I-5 corridor. And then also where you're able to be proactive with jail rosters and making sure that you're getting appropriate people into the cohort.
Yeah, I think we're really excited about this direction that daily data from the jail will allow us to have. It is certainly significant getting the data on an annual basis and being able to see, okay, this person had 6 incarcerations during the last calendar year. But oftentimes what we find, by the time that we are able to locate that person, they may have moved out of county, they may have moved out of state, they may be stabilized on their own and no longer in need of services. So what this daily data will allow us to do is identify the person when they're actively decompensating. So yes, it's great to see when a person has 6 arrests in the last calendar year, but I think it's even more significant to see, oh my goodness, this person has had 6 arrests in the last month, and they're a UHA member, and they have frequent ED utilization. So they would be a really good person to outreach.
So you're outreaching to people in the moment, which increases the probability that they will engage in services versus it was 6 months ago, 2 months ago, and you may have missed your opportunity at that point.
Exactly. And if we can get to people really in those crucial moments where treatment resources, assistance is needed, we're hoping that we can prevent people from going down this long road of decompensation.
And I'm assuming that the flag for the folks in your cohort that is in the electronic medical record helps with that as well?
It does. So we get real time email notifications when one of our cohort members admits to our local hospital or a variety of hospitals throughout the state. We get those notifications. One of the things that our new funding cycle allowed us to do was hire a part time therapist who is embedded at our local hospital. What we've noticed with our cohort is they don't often present to the hospital Monday through Friday from 8 to 5. Oftentimes it's 2 a.m., 3 a.m. Really having this embedded therapist at the hospital has allowed us to educate hospital staff, social workers about what the impacts program is, who potentially, if it's someone who's frequently known to the ED staff, who that person is in terms of being a cohort member and what resources are available to that individual.
And what kind of issues is the therapist working with folks on when they come into the ED at 2, 3 in the morning?
The therapist is really just that point of contact to introduce the program, introduce some of the resources and services that are available through that program. And then if the person is interested in engaging in services, a medical crisis, a mental health crisis can really be a moment of change for individuals. So if somebody is interested in engaging in services, then that therapist is able to do the initial mental health assessment and get the treatment plan set up and get someone engaged in treatment right there.
So it really is the opportunity to engage someone when they are asking for help at the moment versus 2, 3 days later, you need to go find somebody.
Exactly. Or sending them from the hospital with a scheduled appointment. And again, going back to that cycle of unhoused individuals have a really hard time engaging in traditional treatment. So if I'm sending an unhoused person out of the emergency room with a little appointment card saying, be at this address at 2 o'clock on Monday, chances are really good that individual is going to be unable to keep that appointment. Whereas if I'm doing the service right there in the emergency department, then we've got active contact information for that individual. We can know where they're camping at, and then we can get services just set right up from there.
Let's see if Cheryl could share a little bit about the jail patient navigator as well.
Our new grant funding has allowed us to also hire a third outreach navigator. Between the 3 full-time outreach navigators, we have somebody going to the jail every day because that's also a significant moment of change for people. People who are incarcerated are often thinking about what happened to lead up to here, what do I need to do, and they're ready to do some change talk. We found that the jail is a really successful point of contact for people, and we've had a lot of successes coming out of the jail. We had someone recently who has been chronically unhoused for a good 10 years. And this is a person in the community that is pretty easily recognizable. And we were able to make contact with them while they were incarcerated. It was a process. It was a process of really developing a relationship with this person who was pretty mistrustful of a lot of individuals, especially treatment-oriented individuals. So developing a trusting relationship, and it did not happen the first incarceration. It took a lot of going and tracking this person down in the community, making sure this person had what they needed to meet their basic needs. So taking a food bag with us, taking a sleeping bag with us, and making sure this person was able to comfortably meet their needs. But eventually we got to a point where we were able to get this person engaged in inpatient residential substance use treatment while they were incarcerated. So we found a method of being able to get that ASAM done while they were incarcerated. The day the person was released from jail, we met them at the doors and transported them directly over to inpatient, and they completed a 30-day inpatient stay.
Cheryl, that's such a fantastic success story. Can you help the listening audience understand how that looks different than what would have happened if you didn't have navigators?
If we didn't have navigators, we would have to rely on other staff who did not have to bill for services. And again, because somebody's Medicaid is turned off while they're incarcerated, it's really difficult to find staff who can accomplish that task without very specialized funding sources.
I wanted to touch a little bit on the loss of OHP coverage while incarcerated and what potentially the cost of that could be for these individuals who are frequently incarcerated. For example, I reached out to our chief medical officer the other day to ask him about what do we see on the health plan side as additional costs due to OHP coverage being termed while they're incarcerated. You would think that it would be a cost savings to the plans, but it's really not. If you look at it from a perspective of if the individual was perhaps under hepatitis C treatment, which is very costly, it's not a one pill and done type program. So if the individual had been started the hep C treatment and then was incarcerated, potentially that hep C treatment would stop and would have to restart upon their release. The other one is the long-term substance use disorder injections that individuals get to prevent relapses. It's suggested that perhaps while they're incarcerated, those drugs wear off, but they don't get another injection upon release because they're not covered by OHP. And so therefore the relapse propensity is higher for those individuals. So the cost of those injections can be $2,000 to $3,000 per. And so if they relapse, then we have this whole cycle of potential incarcerations, ED utilization, and then going through treatment again. I just want to point out some of the hidden costs for the loss of OHP coverage while incarcerated. The Oregon Health Authority did ask CMS to consider continuing OHP coverage while incarcerated for some of these very same reasons. And while it wasn't approved by CMS for the upcoming 2024 year, they are looking at it, and hopefully the state of California will pick up on this new program and Oregon will follow suit and allow people to be covered by OHP while incarcerated, which I think will benefit.
For our listening audience, I think that's a really important point. It's not the health authority or Oregon's choice. It is a federal choice, and Oregon has to ask for exceptions to those federal decisions. That's that waiver request. Don't want folks to listen to this and think, why are we doing that in Oregon? That's silly. Our hands are a bit tied on the federal level on being able to continue Medicaid. In the grand cycle of programs, it hasn't been very long with the Impacts grant. So I'm wondering, have you been able to see any outcome data on how folks are doing or what it's looking like financially and saving costs by spending money in a different way?
We can definitely see a cost reduction for the individuals who are engaged with Cheryl's team through the healthcare costs and jail costs. Since we are tracking both costs, we do record the number of days in jail for each individual, and we quantify that by the jail bed cost at the time. And we also track pharmacy and healthcare costs on a daily basis for each of the individuals. For example, we had an individual who had over 119 ED visits. Cheryl's team engaged the individual. They went from 46 ED visits in 2021 down to 1 ED visit in 2022. So you can just imagine the cost savings for an individual that's frequently in the ED to drop that dramatically in a year.
And just to piggyback off that story, talking about somebody, I think they had at one point like 19 ED visits in a 1 month period. And some of those they presented to the ED via EMS. So that escalated the cost of that encounter. And so when we came in and we helped connect, this person had some very real physical health problems, but it also seemed like they were using the emergency department maybe as some social supports too. So when we were able to connect that person to the appropriate primary care and then get that person engaged in the appropriate treatment options, we found a drastically reduced number of hospitalizations. But then we took it one step further. We noticed that after the team would go home in the evening, the ED utilization may go back up, but they were not able to access the team. So using a method of almost skills training to teach the individual, instead of going to the ED, why don't you try and call one of the outreach navigators first? Or let's call the warm line and let's talk to someone for a few minutes. So eventually we got to a point where it became really clear that this individual may need further support, some supported living arrangements. We were able to make arrangements to use some of the impacts funds. I think we spend about $600 a month in impacts funds to support this person in an adult foster home setting. And in return, the cost savings from only having one emergency department visit in the last year is astounding.
My mind is boggling at the possibilities. But for the listening audience, let's talk money. So, what are we talking about the difference in 2021 with what you said? How many ED visits? 40 something?
46.
46 ED visits in 2021. And now one ED visit this year, and then the money that you spent. So, around ballpark, how much did you end up spending on this person?
$600 a month for housing cost.
And then how much was ballpark being spent in 2021 for 40 something emergency room visits?
I think we estimated the cost avoidance on this individual at about $89,000.
$89,000. And we're talking about one
One
person.
one person.
And how many people are in your cohort?
333 original members.
So one person, $89,000, and over 300 people in the cohort. So listening audience may think math is not my thing, but think about the amount of money that we're saving by spending money in a different way to meet people where they are versus expecting them to fit into our traditional system and keep doing the same thing over and over again and expecting different results. If you don't talk about lives changed, if you just talk about money, it's a huge difference. And then let's talk about lives change, because the money matters, but the lives change are really the difference that truly matters in this. And Cheryl, I'm sure you have fantastic stories to tell.
Yeah, the lives changed. It's exceptional to see what happens to someone's life when they're supported in identifying their own unique barriers. And it's different for each person. When they're supported in identifying their unique barriers and then given resources to reduce the impact of that barrier. So we have another individual who, gosh, Sue can give the exact number, but had an incredible number of incarcerations in a 1-year period. And this is the person who, we're in rural Oregon. We have 3 or 4 grocery stores in town. This is the person who would oftentimes be seen at the camp outside of one of the major grocery stores, pretty easily recognizable for being intoxicated in public. And we were able to really form a relationship with this person by identifying their barrier to meeting their basic needs. Basic needs is so humanizing. It's a really effective way of establishing a therapeutic relationship with someone really quickly. I see you as a human being. Tell me what you need to take care of yourself. So providing this person with sleeping bags, tents, food items, warm clothing items, it created this trusting relationship with this individual. So we were able to create a relationship with this person where eventually they started seeking us out. So they would come into the office to seek out impact staff. And we worked from there. We worked on housing applications. We worked on mental health court. We worked on different treatment options. We worked on getting involved with a psychiatric provider. All of these things led to a scenario where slowly this person started to engage in services. They were able to fill out applications to receive a HUD voucher for housing, and then use that voucher to get into supported transitional housing, where they've been amazingly stable for the last 1.5 years. Their whole mindset has changed from survival to now thinking about what are the tasks and things that I need to accomplish to actually thrive. So they are looking at their credit score and recognizing that their credit score may impact their ability to get the housing that they want. So what do they need to do to correct their credit score? They're looking at, how do I get my driver's license back? Because I want to be able to go to school and I need to be able to drive or get to school. So taking the appropriate steps to get their driver's license back. They are looking at building their resume and volunteering at different places within the community to be able to get some form of work experience.
So, thinking about that for this person, Sue, how much were we talking about in jail costs versus Cheryl? How much did we end up spending working with this person?
For this individual, the ED cost avoidance is $36,000 and the jail cost avoidance is $15,000 for a total of $52,000.
And I think from the impacts funding perspective, it was a relatively low cost for us. We supported with a couple of months of initial housing funding while their housing voucher came through. But as of right now, we're assisting with application fees to the DMV, and that's it.
So, an amazing difference in cost avoidance by being able to use funds to meet people where they are for what they actually need in order to do better versus how we have to usually spend money to make them fit into what we think they need to do better in order to fund it. I think that these stories really highlight the importance of rethinking our funding within the traditional system. What's exciting is with this impacts grant, there is a cohort of folks who do meet criteria for these monies. And yet, I'm also wondering if this type of more flexible funding was available through the traditional system, if there are people that don't quite meet the criteria for the impacts grant, but would benefit from being served in a different way.
I think there's certainly a portion of the population, especially in regards to our unhoused population, where they perhaps don't meet criteria in terms of they don't have those frequent incarcerations. However, asking someone to engage in traditional healthcare appointments and services can be really difficult for individuals, whether they're unhoused or even folks who live in a really rural community such as Douglas County. We're talking about communities that may be 45 minutes to an hour away. And for people who are without adequate income, finding $20 to put in the gas tank to make it to a traditional healthcare appointment can be really difficult.
Sue, I'm wondering if you have any data in your pocket on overall how much cost avoidance has occurred because of this program over the last couple of years.
The Criminal Justice Commission actually reached out a couple months ago and asked us to come up with an estimate of the cost avoidance that we've done under the impacts grant here in Douglas County, which was quite fascinating to me to do. Part of it, though, is hard to determine due to the effects of COVID in the healthcare system. In the jail, capacity was reduced, so they were citing and releasing people rather than booking and releasing them. So we don't have any of the statistics around the actual bookings because it was limit restricted jail capacity during that time. So we can demonstrate jail bookings went down dramatically from 2019 to 2020, but it wasn't entirely due to the efforts of the impacts program. But we can demonstrate that the bookings have decreased from 2020 through 2022, along with the ED utilization. I just did the math real quickly. It's dropped 32% from 2021 to 2022 for the impacts cohort, which is significant. I was caught off guard when I looked at the total healthcare costs, which includes more than ED. It includes all healthcare costs, including pharmacy. And I did see an increase in 2022. And I'm looking into that in more detail. We did have a success story of an individual that is now undergoing Hep C treatment. And so those costs, as I mentioned earlier, are extremely expensive. And so that has increased our healthcare costs. But in the long run, the investment is worth it as a health plan to treat Hep C rather than if it's left untreated. So we do monitor these on a daily basis because the information we have through our analytics is updated every night. And so it's just fascinating to see the daily updates of the jail booking and releases, and then the healthcare costs associated with these individuals, as well as now having a fluid cohort of individuals where we can identify them sooner rather than waiting until they've been booked 15 times and then go, oh, okay, we should probably engage this person. So that's the exciting part we're really looking forward to in 2023.
Do you have a rough amount of cost avoidance for emergency room and jail by the use of this program over the years?
I could say that the ED visits went from 504 in 2019 down to 288 in 2022. The costs were rough at a high point were about $550,000 for ED costs, and so far they're about 335. So it's a couple $100,000 of ED savings just in the emergency room.
Wow.
Utilization decrease, yeah.
Wow. Cheryl, I'm wondering, do you have anything to add to that?
Only to say that I think we're all really excited to see what happens with the Impacts program in 2023. As part of our new award cycle, we were given funds to purchase and renovate a local hotel, which is going to be used in part for Impacts folks coming out of the emergency department, coming out of jail, a temporary housing location to, again, just allow people to meet their basic needs and engage in whatever services or options that they decide will work best for them. I think we're really excited to see what sort of impact that can have for a cohort.
So this money has allowed you to have a couple navigators, 2, 3?
We're up to 3 full-time navigators and 1 part-time therapist.
3 navigators, 1 part-time therapist, 2 crisis beds, a sobering center, and now you're looking at temporary housing through a hotel.
Correct.
That's impressive.
Some really exciting resources for our community.
Absolutely. Game changer in a rural community.
Absolutely. And I think here in Douglas County, we've had a lack of some of these resources for so long that it's really exciting for mental health and substance use providers. And it's exciting for UHA. It's exciting for law enforcement. It's exciting for all of these invested community partners who have been talking about these are the resources that we need. And we're finally at a point where those resources are happening.
I'm wondering, Cheryl, just because I'm a curious person and I can't help myself, I do a lot of work in the fitness to proceed realm and the civil commitment realm. I'm curious if you're seeing any differences in those realms with money being utilized through impacts.
Not necessarily on the number of civil commitments or the number of aid and assists, but I think where we do see high level of intersection is with our mobile crisis team and impacts. We have a pretty robust mobile crisis team who works really closely with impacts. Our mobile crisis team will get called out with law enforcement as they're actively engaging with people in the community. And because they work so closely with impacts, they're able to identify when an individual is an impacts cohort member. They're able to call the impacts staff and get them out to the scene so that we can really safely provide intervention to someone in that acute moment and provide the resources associated with impacts.
Wonderful. I think this highlights the importance of having lots of different tools in our tool belts to meet different populations and recognizing that there are different populations with different needs in the community and that we need to have different kinds of programming to be able to address those needs. That this may be a different population where we're looking at high jail and ED utilization costs that necessarily don't rise to the level of civil commitment or competency restoration, and yet are a population that really do need services and are impacting the bottom line within communities. And so being able to have a variety of options in working with people is really important in the community and some flexibility.
I think that's one of the things that has made impacts truly successful is that it's a funding source that allows us to be flexible and creative and really look at the entire person versus traditional CMHP funding where someone had to meet very specific requirements to utilize that resource.
Speaking of traditional, I'm also curious. I have heard folks talk about some barriers to treatment. Traditionally in healthcare, there is like a ridiculous amount of paperwork and things that need to happen in order to get somebody into services when you go the traditional route. And sometimes when folks have lots of things going on, the last thing you want to do is do an incredibly thick intake packet and sit through intake and talk about their trauma. So I'm wondering, through the impacts grant, does that look different for you all than the traditional way of doing things?
It does. So, one of the benefits of our impact staff is that these are not traditional in office 50-minute appointments. These appointments tend to be 2-3 hour long appointments to do things such as fill out paperwork or intake packets, and not just to mental health services, but to primary care. They have an equally long packet of information that needs to be filled out. So, really, it's not a matter of making an appointment for someone at this primary care's office. So be here at 9 o'clock. It is, I'm going to pick you up at 8:30. I'm going to call you the night before to remind you I'm picking you up at 8:30. I'm going to pick you up, and then I'm going to go in with you, and I'm going to help you and support you through the process of filling out that packet. And if you want me to go into the doctors with you and advocate for you, we'll do that too. And then when you're done with the appointment, we'll take you to the pharmacy, and then we'll take you home and we'll remind you of your next appointment. They are very much peer support, skills training geared appointments rather than traditional healthcare appointments.
And how important that is. Listening audience, think about when you've been really sick and you have to go in to see the doctor and they give you all this paperwork and you're so sick. And you just want to see the doctor, right? Think about that for yourself and the follow up and going to the pharmacy and getting yourself to the doctor. Now, think about if you had a lot going on in your life and you had a lot of complications going on in general, but also within your functioning, the difference it would make to have somebody there with you to remind you that you have this appointment, take you to the appointment, be there with you when you're trying to fill out the paperwork, advocate with you, take you to the pharmacist. What a huge difference that is for folks. Just thinking about our own lives and going to the doctors when you don't feel well, but also then extrapolating from there what it would be like for someone who's dealing with some pretty significant symptomology and challenging life circumstances. Is that a fair way of looking at it?
I think that's accurate.
I'm curious if you have any final thoughts for our listeners or anything else that you wanted to talk about.
My perspective, I've enjoyed working on this program, and I think it speaks to the community level involvement of everybody in this community who's involved in the Impacts Grant. It's more than Cheryl and I, it's the hospital, it's the jail, it's the juvenile center, it's the local tribe. They're also part of the Impacts Grant recipients. And without the support of all these community partners, I don't think we would be as successful as we are today. I personally have really enjoyed working with Cheryl's team, collecting all the analytics around it. Her team sends me a weekly report of every encounter that they do and supporting these individuals who are engaged so we could track that and demonstrate to the Criminal Justice Commission exactly how much effort we're putting into the outreach programs for these individuals, and then demonstrate the success of the Criminal Justice Commission's Impacts Grant here in Douglas County.
I would echo Sue. I think it's just a huge testament to the relationships that we have in the community, how successful this program has been. This program is not just about Umpqua Health Alliance or ADAPT. It's about the jail. It's about the sheriffs, the local officers, the lipstick committee, and all of these different community partners who saw a need and came together and have really worked together to make an incredible program.
It really is about all of us coming together to think about things in a different way and work together to solve the problem. Anything else that UE didn't cover that you want to talk about?
I was looking at some stats here on cost avoidance. And through the research I was able to do of following an individual from arrest through parole and probation, the average cost is just over $13,000. That's from a research paper several years ago. But if we apply that, we can demonstrate that we save over $1 million a year by the reduction in incarceration rates through the Impacts Grant cohort population. So that's significant dollars.
Absolutely. And that's just 1 year. It's just for criminal justice costs, not ED costs.
Yeah, that's arrest to parole and probation. What we track is the jail bed costs, which is a very small piece of it when you think about the arresting officer and then booking them through that process, going to court, all of the court related costs, and then release and parole and probation costs on top of that.
Pretty significant difference versus the monetary investment for impacts and what you were awarded. So your award for impacts, remind me, over the course of impacts has been how much?
The first funding was 1.4 million in 2020. And then the second funding that just came out in July was 1.3 million. So a total of 2.7 over 4 years.
2.7 over 4 years. And you're looking at, did you say $1 million in a year for criminal justice alone?
Yes.
Just looking at criminal justice, not even looking at ED. You talk about significant savings and thinking about how we're spending our money in a different way.
Yes. And changing people's lives.
Yes, that's the most important piece, is changing people's lives. And if you're not convinced by changing people's lives, just look at the difference in the money and how it's being spent. But I think the changing people's lives and the stories that you have, Cheryl, are just amazing. Do you have one last story for us for the end to remind people that it's not just about the money, but how we change people's lives through this process?
The one that comes to mind that I haven't shared yet is an individual who was released from Oregon State Prison. And while they were incarcerated, were exchanging written correspondence with the impact staff, identified that they probably could get their old job back once they were out of custody, but they would really love some help with some sober and safe housing. And so impacts funds were used to pay for 2 months of an Oxford house, which is a treatment-focused supported housing. And this person was off and running. They had a safe place to leave the prison setting, to a safe spot to land. They had a job waiting for them, and they were very easily able to integrate back into stable lifestyle after their period of incarceration.
That is a wonderful story, and I think a good reminder of we want folks to be good neighbors, and using money in a different way really helps support folks in being able to meet that goal into returning to the community from incarceration and becoming our neighbors again. I thank you for the work that you do. I am so excited to hear about how you are looking at how to meet folks' needs where they are in order to help them have better lives, and also improving the financial bottom line along the way, and the life-changing efforts of your teams and everybody working together within Douglas County. So thank you so much for the work that you do and taking the time to be on the podcast today.
Thank you for having us.
Thank you.
The Center Collaborative is a production of the Oregon Center on Behavioral Health and Justice Integration, a specialized division of Greater Oregon Behavioral Health Incorporated. It is produced by me, Chris Thomas, with production assistance from Patrick Kennedy. Music by Pat Mulvihill and Patrick Kennedy. Subscribe to the Center Perspective using your favorite app. To learn more about criminal justice and behavioral health integration in Oregon, visit the Center's website at ocbhji.org. You can also find us on Facebook. We'd love to hear from you. Please reach out to us. Join us next time as we chat with the experts about programs and partnerships that work within this complex and yet compelling field. Thank you for joining our conversation.